at, are there issues with the clitoris? Is that where the pain is originating from? Are there issues with the labia? Is there issues with the labia majora, the minora, any of those things? Could it be bladder dysfunction? Could it be pain with the urethra? So all of this. So that is what we call region 1, and that is kind of like the end organ. Region 2 is what Dr. Colon is going to focus on, and that is the pelvic floor muscles. And so, where is it that there is pain? Where is there tightness? And how do you assess for that? Region 3 and 4 that we talk about has to do with the spinal cord. So lower part in the spinal cord near where is the cauda equina, which is basically where the spine kind of ends and the nerve roots come out. That's called the cauda equina. And sometimes there can be pain there at the nerve root that is causing pain in the end organ. So the pain that you feel may not be where the pain is originating from. And that's what I'm talking about. So that could be region 3. That could be coming from the spine. Region 4 is higher up on the spine, right? So we know that the nerves control the nerves that come from the spine, innervate the vulva, innervate our whole body. We have nerves going everywhere. And sometimes that pain that we think is coming from the pelvis could actually be originating further up. So that's that region 4. And, there are ways that we look for where that pain is stemming from. And region 5 is at the level of the brain. So maybe is it medications? Is it past trauma? Is there, are there other things? Is there depression, anxiety? Are those things going on that's causing you to feel anxious? That's maybe showing up in the vulva. There are people that I have met, patients that have a very negative reaction to their genitals, to the vulva, because of either past trauma, or if they have a history of, say, cervical cancer, or, abnormal pap smears where they've had to have like multiple procedures done on their cervix. And, I had a patient come and she absolutely just could not even take a look at herself. She was very, very upset and just had a very poor relationship with her own body. So, all these are very important things to take a look at. I'll just talk a little bit about this pelvic pain and kind of how we characterize it. And then we can definitely, I'll finish up my section and then Victoria will start talking about hers. So, when we talk about genital pain, penetration disorder, basically it's characterized by persistent pain during sexual intercourse. And it is, or other forms of penetration, right? So it doesn't just have to be sexual intercourse. Some people have pain with insertion of a tampon. Some people have pain with basically a pelvic exam. So it could be any one of those things. And several conditions are classified under this. So we have vaginismus, and I'm sure Dr. Colon is going to get more into that. So I won't talk about that. But it's basically involuntary contractions of the muscles surrounding the vagina in anticipation of some type of pain. And definitely when somebody experiences vaginismus, that is one of those dysfunctions, like sexual dysfunction, that you absolutely need a therapist. You need, pelvic floor therapist, and you need a sex med doc if you are, going through this pelvic pain. Diagnosis is based on the presence of more than one of the following. And, we can talk about one of the following symptoms for more than 6 months. So it's deep pelvic pain and tension during penetration, or superficial burning, vulvovaginal pain caused by even the slightest touch. There's definitely fear and anxiety before, during, or after penetration, which often leads to decrease in desire. So, of course, anytime you have pelvic pain, you're not going to want it, right? So, unless that's something that you're seeking, and that's, different forms of like kink and things like that, but we're not here to talk about that right now. What we're talking about is just pelvic pain in general. And a lot of times when you experience pain, you're not going to want that. And so that's why that can lead to decreased desire. Also, tensing or tightening of the pelvic floor muscles, what we talked about. And, this has a tendency to cause severe distress and problems in a relationship. I've seen a few patients actually very recently. One that comes to mind, she has something called lichen planus, which was causing cuts in the vulva, and she was having a lot of pain. And she also started to have some type of like bacterial infection because she was getting cuts also inside the vagina as well as out on the vulva. And that was causing a bacterial infection, which then, was causing a whole slew of problems. And so every time she would have intercourse, she would bleed, she would have this discharge, it was just a mess. And she was in so much pain, and she suffered for 3 years before she found me. And, we went through all the diagnosis and just kind of taking a look and examining, and I realized what she had. I treated her with the appropriate steroids for the vulva, and then also for inside, there's steroids, estrogen cream, and also an antibiotic cream that we put inside. And 3 months later, she's doing much better, and she's finally able to have sex. She hasn't been able to have intercourse for the last 3 years, and so she is telling me how this has really changed her life. And it's really important to know that if you're having pelvic pain, it can be due to so many different causes, and that it's really important to see somebody to see what exactly that cause might be. I don't really know how many slides we'll be able to get through, but this is just a picture of the different regions that I was talking about region 1, region 2, 3, 4, and 5. And this is a picture which I actually feel that, they always say that, right? Pictures are worth 1,000 words. And I feel like this picture really says it all, because it shows you the end organ, it shows you the vulva, right? And this is actually a picture from my friend Rachel Rubin. And then we have the pelvic floor, which you can have a lot of, dysfunction there. And then you have the spine. You see the end of the spine where the nerve roots come out, which we call the cauda equina, and then higher up on the spine. And then, of course, at the level of the brain, right? So this is just kind of a little picture, which I feel like it helps a lot to talk about what is really going on. Here we have, and I know that I have 10 minutes, but so here we have just a picture of where all this vulvar pain can begin, and so persistent vulvar pain can be chronic, and it can cause discomfort in the vulva that can be described as burning, stinging, irritation, or rawness. It happens for at least a 3 months duration. It can be localized, generalized, or mixed. It can even be provoked, spontaneous. It can be primary or secondary. It can be intermittent. So that's why it's really important to know what is going on, because we need to, as providers, when we see you, it's really important if you can tell us, what it feels like when you have this pelvic pain. Do you feel it on the inside, the outside, where it is? If you can point to it, if you know the words for it, if you can tell us if it's, if you've always had it, that would be something that was primary. If you just got it, that would be secondary, or if this happened, due to perhaps you used a different detergent, or you used a different condom, or, sometimes that can cause some pain. I had a patient, I have to tell you the story. I had this patient, she came in literally 2 weeks ago. She made an appointment at 1 a.m. She was in so much pain, and she just found me on ZocDoc, and she, made an appointment. And what happened is that she said, I have this horrible, horrible burning on urination, and I just don't know what it is. It is causing so much pain. And she's like, she went to the Minute Clinic, right? So she went the day before, or 2 days before, she went to just like a CVS. She went to Minute Clinic. She went there. She saw a nurse practitioner. And, those places don't necessarily have offices where, the patients can be examined, right? So the nurse practitioner, thinking based on what that patient is saying, the patient is saying, I'm having burning on urination. The nurse practitioner was like, it sounds like a UTI. I'll just go ahead and give her this medication for UTI. Well, it turns out that it was not a UTI. And in fact, when she made the appointment, when she came in and she told me she was having burning on urination, that was actually the last thing that I was thinking, that it was a UTI, because I was pretty sure that even before I examined her, I had a feeling that it was going to be something else, because I had another patient that had the same complaint of burning on urination, and it was not a UTI. And so I went and I did the exam on this patient, and this poor woman had a full-blown episode of herpes. And because she was not examined by the previous practitioner, and because they didn't know what they were looking at, because they never examined her, they just assumed that she had a UTI, and they just gave her antibiotics. That's why it's so important that although I love telehealth, I think telehealth is fantastic, especially in like rural areas where there is definitely a desert for physicians and clinicians. It's really important that if you have been suffering with something that is causing severe pain, definitely go to a doctor's office to be evaluated. Because when you tell your symptoms to somebody, somebody may think it's, a UTI. When you go in and then I examine her, and it actually is her first episode of genital herpes that is causing severe pain. And the reason why it burns when she urinates is because the urine is acidic, and it is touching those lesions that are on her vulva and on her buttocks. And that's what was causing her severe, severe pain. She had actually lesions that may or may not have, I mean, they didn't really look like they were herpes, but they could have been herpes. And, but it turned out it was herpes. Anyways, I treated her because I had a feeling, and I knew that this is what was causing it, because her symptoms were burning and it was tingling, and it was, there's so much pain associated with this that I was like, this has to be herpes. So I treated her, and then I saw her the week after, and I'm telling you, she was like a different person. When you have the correct diagnosis and when you are treated with the correct modality, the result is going to be fantastic. She was not in pain anymore. All of her lesions scabbed over, and she was so, so grateful. So my point in telling you this story is that, sometimes when you tell somebody over, telehealth, or if you just go somewhere and you're not really examined and you tell them your symptoms, they may think that you have something when you actually, in actuality, have something else. So that's why that was really important. Because her burning on urination was due to the fact that the urine was, on the lesions, the urine was going on to those lesions. I bring this up, this is a picture of Brooke Shields, and basically just talking about how in popular media, we see it all the time, where we see that patients are not being heard, they're not being listened to, they're being dismissed. And so Brooke Shields talks about how she went in for a labiaplasty, basically just because her labia were bothering her. They'd been like chafing, they get caught in her, underwear, whatever. She felt like they were too long and she wanted to get it fixed. And instead, that doctor did that, but he also did an additional surgery without her consent, which I don't even know how that's possible. I don't know how you, as a physician, as a clinician, you can do something on somebody's body without their consent. And well, that doctor did. And she goes and she writes about it. And I'm surprised she didn't even, sue her doctor. But I mean, can you imagine having something done to you without your consent? Okay. So, this, hello? Yeah. So, this is something called vestibulodynia, and I'll try to go through this really quickly. Basically, this is where individuals can have pain with entry into the vagina. And sometimes this can happen as a result of birth control pills. So really important to know that sometimes the medications that you're taking, a side effect of it could be that it can cause some pelvic pain. So really important that if you are on birth control and you notice that once you started birth control, you started having pain with penetration, pain with entry, and then you go and get that evaluated by a physician, because it could be due to your birth control pills. And some birth control pills will do it more than others. Not everyone that has that takes birth control will have this vestibulodynia, but some can, and really important to know whether or not you do. So if you are experiencing pain with intercourse, you definitely should get checked out for that. Again, these are just a few things that again, they're in the popular media, they're articles, things that show up. This is the link. This was a New York Times article that talked about the link between birth control pills and sex drive, and talked about how you can have decreased sex drive with birth control pills. And the reason behind that is because birth control pills will activate because they are pills, they will activate the liver. The liver releases something called sex hormone binding globulin, which kind of acts like a Pac-Man that eats up the free testosterone in your body. And when it does that, we know that testosterone is responsible for libido. And when you have decreased testosterone, it results in decreased libido. And birth control pills can also cause you to have pain with sex, right? So it's like kind of like a double whammy with birth control pills. We love birth control pills as gynecologists for, contraception and for endometriosis and for acne and so many other things. PCOS, we give out birth control pills like it's water, but important to know that sometimes these medications can also have some side effects. And again, this is a few articles. Halle Berry has been all over the news. She talks about menopause. She has a new business now that she's focusing on menopause, but she talks also about how she went to her doctor saying that she was having this horrible pain with sex. The doctor told her she had herpes. It turns out she did not have herpes. She actually had genitourinary syndrome of menopause. What that is basically a syndrome of menopause. So as the estrogen declines, you have decreased blood flow to the vulvar region, which can cause problems with you. So you can have pain with sex. You can have decreased lubrication. You can have problems with orgasm. You can have recurrent UTIs. You can have overactive bladder. And you can experience all of these things due to, and it can start in perimenopause. It can also happen anytime you have decreased estrogen. So for example, if you're a newly postpartum woman that is breastfeeding, that breastfeeding happens because you have a decrease in estrogen, and because of that decrease in estrogen, you can have pain with sex. So really important to know that if you are having pain with intercourse, that is not normal, and you should definitely be checked out. And I am going to stop there because I know that we have 2 other presenters, and I want to leave time at the end for questions and answers as well. But that is my portion of the presentation.
Well, thank you, Dr. Lodhi. I am Dr. Victoria Colon. Let me pull up my presentation for you guys. Okay, so I'm a pelvic floor physical therapist. I'm the owner of V Strong Physical Therapy, which is my practice located in Armonk, New York. So I'm going to go through the role of the pelvic floor during and how it relates to pain with sex. Okay, so what is your pelvic floor? And I know Dr. Lodhi touched upon this as well, but I want to show you guys the pelvic model. So this right here is the pelvic model, and everything in red that you see is actually pelvic floor muscle. So it's not just one muscle, it's actually over 20 different muscles. It extends to your sit bones, it extends to your tailbone. And as you can see, it forms a basket. So it really does provide a lot of support to the organs that sit in it and on top of it. It also is responsible for bladder and bowel control. And in addition to that, it plays a huge role with sex. So arousal and orgasms are also controlled by the pelvic floor muscles, or contributed by the pelvic floor muscles. When I talk about pelvic floor dysfunction, this is a wide or general term, but essentially it refers to any dysfunction that could be going on with the pelvic floor, whether it is the muscles are too tight and or weak. Usually there is a combination of both. I think, commonly we hear, you need to do Kegels, your pelvic floor is not strong, that will solve all your issues. That's, I would say, 95% of the time, not the case. And yes, you can have, purely just a strength issue or weakness, but most of the time there's a tension issue. And when a muscle is tense, it can't function properly. It can't coordinate properly. It doesn't have good endurance. It can't lengthen properly. And this can be a huge cause of pain with sex. So we're going to talk a little bit more about that. But going back to when the muscles are too weak, this usually can be associated with difficulty with arousal or with orgasms. So we're going to now talk more about the tension issue and how that can relate. So when I'm referring to when your pelvic floor muscles are too tight, because there's so many different muscles, there's so many different areas where this tension can be. And that's why, as a pelvic floor physical therapist, my job is to locate the areas that can be contributing towards the pain that you're experiencing. A patient may come in and say, I think most of my pain is upon initial penetration or insertion of a tampon, or it's with deep penetration. And then once we're going through the exam, they find out, okay, actually my pain is located in this spot or on this side. I thought it was on this side. So basically I'm being an investigator to find out where are the areas that are causing the pain. And then once we can locate the areas that are causing pain, treatment can look a variety of ways, which I'll get into. But for right now, I want to focus on the location. So if the location of pain is coming from your superficial muscles, which are, we call layer 1 muscles or muscles at the opening, then the way that we can help to alleviate some of the pain or tension in that area is by doing stretches to those muscles and to the surrounding muscles. So this typically looks like stretches that work for hip external rotation. So when I say external rotation, you're going to think knees out, feet in. So if you were imagining in your head like you're doing a squat and your knees are out, but your feet are closer together, that is the position that you would then go through with stretches such as butterfly, happy baby, and that can help to open up that area. In addition to that, we know that also certain muscles attach to the opening or share fascia that goes over that opening, or the muscles that surround the opening. So for instance, your hip adductors, which are your inner thigh muscles that extend, that start from your pubic bone and go all the way down to your inner knee, those can typically also be associated with pain at the opening. So doing stretches like hip adductor rockbacks, which is when you're on all fours and then you have one leg kicked out to the side and you're rocking back and forth so that you feel that stretch in that inner thigh. Typically, patients will feel the most stretch or pain proximally or towards the pubic bone when we go through this. So that can be a way that we're targeting it. When we're now trying to focus on pain with deep penetration and focusing on those deeper pelvic floor muscles, we're going to do the opposite. So hip internal rotation. So you're thinking knees in, feet out. And for that, just some examples of some stretches or exercises. Lower trunk rotation. So this is when you're on your back, your knees are bent, and you're just swaying your knees from side to side. And as you sway to one side, the knee that is collapsing inward is going to then be where you're feeling that hip internal rotation stretch. And then if you switch, it's the knee also that's collapsing inward. And those are just some examples. There's other stretches or techniques that I'll show patients as well. But I just wanted to give you guys an idea of what this would look like depending upon the location. Okay. So in addition to that, we're also going to be going through breathing. So breathing is a really effective way to help get the pelvic floor moving. So we know that your pelvic floor works in conjunction with your diaphragm. So your diaphragm, you can think of this dome-shaped muscle that sits below your rib cage. And as you inhale, your diaphragm contracts and goes down, as you can see in the picture. And with that, your pelvic floor is supposed to work in synergy with it and also move down. So by working on the inhalation, we're getting that relaxation of the pelvic floor. And then when you exhale, your diaphragm moves up and also your pelvic floor moves up or reflexively recoils. So by going through the breathing, we can then work on getting a deeper inhalation to areas that may be limited. So just looking at how the person's breathing. Are you limited in getting breath? We call this like anterior, posterior, breath forward, breath on the sides, or breath in the back lungs. So we know that you need to be able to get breath 360 degrees, not just, into the belly. It has to go everywhere in order to hit all parts of also your pelvic floor to open and lengthen. So that is one of the techniques that we're going to be working through. And with that, we're also going to be working through different positions based off of how you're breathing. So for instance, if a patient really struggles with getting breath into their left rib cage, we can then focus on having the patient go onto their side and trying to open up that area more, or maybe putting a pillow underneath the opposite side to even open it up more. And these are techniques that you can also do before you are going to be intimate. Not that you want to prepare, because of course intimacy can sometimes be a spontaneous thing, but it's how can you also bring attention to relaxing that area, so that when the moment happens, you're not caught off guard, and you feel a little bit more at ease. So those are ways to work on the breathing, and try to get the pelvic floor to relax more. In addition to that, with pelvic floor therapy, sometimes I will recommend having patients use dilators, wands, or O-nut. So I'll show you what that looks like. I have them here. So these are dilators. They are silicone. They're very soft, and this is a vaginal dilator. So you would use this, and there's a whole progression that I go through with patients. It is not something that it should just be, given to like use dilators. You do have to go through a progression to make sure you're safely and effectively using them. And so basically what the dilator does is it helps to provide a stretch to the vaginal canal, which is then providing a stretch to your pelvic floor muscles. So this can be a great technique, or supportive technique to use for patients that have vaginismus, with vaginismus, they're having that involuntary contraction of the pelvic floor muscles. So by them having some control by using a dilator, they can then understand the difference between when they are contracting and relaxing. And that is the dilators. We also can use a pelvic wand. This is also silicone, and both the dilators and wands are from Intimate Rose. That is the brand that I recommend. So the pelvic wand, it looks a little intimidating, but I promise you it is not. This can be used on either side vaginally, and it can help to target trigger points that you have in your pelvic floor. So this is something that upon doing an internal exam with a patient, as long as there is consent and it is appropriate, we would then find the areas where they have trigger points. And then I would direct the patient on how to use the wand to reach those areas. And this can also be an effective tool for them to use outside of therapy. And last but not least, we have O-nut. So I don't know if you guys have heard of O-nut, but these are rings that are placed on the penis, and you can stack them. You can use all four, or you can use as many as you need. And basically what it does is it prevents you from having penetration at the point where you're feeling pain. So it really depends on at what point you start to feel the pain is then how you would modify how many you're using. You would start with all four to be on the safer side, and then if you need to take some away, you can. But I do want to note that these are all supportive modalities, and it is something that should be guided with pelvic floor physical therapy. Okay, so how pelvic floor physical therapy can help. So with patients that are having pain with sex, which is a very common issue that I see along the entire spectrum, we are working through doing external release of pelvic floor muscles, internal release as long as it is appropriate and there's consent. And then in addition to that, doing stretches based off of the location of pain and other surrounding areas. So I know I focused on, the hips, internal, external rotation, but there are many other muscles that could be also contributing to why they are getting this pain with sex. Are their abdominals tight? Are the hip flexors tight? Are the glutes tight? These are all muscles that share connections with the pelvic floor, either directly or indirectly. So it's important that we target those areas as well and not just the pelvic floor. And in addition to that, I will also be giving position tips based off of where the pain is and how to have them best prepare before and during intimacy. What breathing techniques they need to use. Do they need to perform self-stretching, whether that's using their finger with lubricant or using a dilator? It really depends on where they're having that pain. And that is it for my portion. If anyone has any questions right now, we can, take a second if anyone wants to put any questions in the chat before Shoshanna, you take over.
I'm just opening up the Q&A box. Let me just, I think you're able to get to it at the bottom of your screen. So if you have any questions right now, you can pop them in. I'll ask a question. You can also post anonymously. If you prefer that way, there's a box you can check to post your question anonymously. I'm just going to type in a question so you guys can see where you can type it in. If you can see that, I hope people can see it, that there's how to ask questions there.
Yeah, I can see it. I think we
Okay.
can see it.
Mhm.
I think maybe if nobody has any questions, we can perhaps continue with yours, and then we can maybe save all the questions for the end.
There wasn't a question, but someone wanted to say thank you. This is great, but from Fiona.
Thank you, Fiona.
I'm glad people can see it. No question, but I wanted to learn everything about the pelvic floor from Danielle. Okay. Let me pop up my presentation right now. Okay. So my name is Shoshanna Rome. I am a perinatal maternal mental health therapist, and my office is in Mount Kisco. I've been working with women and families in various roles for over 15 years now. I'm not just as a therapist, but as a birth doula, postpartum doula, and also a birth educator. I feel like I've learned so much even just today from Dr. Lodhi and Dr. Collin. So this is really great to be a part of this. But today in my section, I'm going to be diving into a topic that's like pretty personal for many people. And we'll be talking about how trauma, specifically birth or sexual trauma, can impact our ability to feel safe, and thus also impacting our connection at times in intimate relationships. In the next few slides, we'll explore the body science, the emotional impact of trauma, and also we'll talk about, most importantly, ways that we can start the healing process. So trauma and intimacy, there's the disconnect. The quote, "Have you ever felt close to someone emotionally, but your body couldn't follow?" This quote resonates with so many people. And many of my clients have expressed their own version of this question. Why doesn't my body follow my brain? Someone might feel deep love for their partner, but recoil at their touch or their partner trying to initiate sex. And that disconnect is often and sometimes the result of trauma. And today we'll unpack why and how that happens. So trauma's impact on the brain. We'll talk about the 3 different parts of the brain that kind of is impacted the most. Studies have shown that trauma can cause lasting changes in the brain's fear and regulation systems. The amygdala, which is if you see in the picture, the red and brown area, the brown area with the red at the tip there, that part of the brain becomes hyperactive after a traumatic experience. And it's essentially our internal alarm bell, and it's constantly scanning for danger. For someone with a history of trauma having difficulty with intimacy, this can look like jumping or having like a tightness in the body when a partner gently touches you, or suddenly feeling like dread or panic when you feel like there's pressure to be intimate. And then another part is the hippocampus. That's the yellow part of the brain on the slide. And this part of the brain helps us make sense of time and place. So they've seen that after a traumatic event, sometimes this area can shrink. And what happens there is that it can cause things like flashbacks or intense emotional reactions that feel like the trauma is happening right now, when in reality, maybe there is nothing really unsafe going on, but there's something that's triggering that response. And well, an example of that is like someone's body might suddenly feel like she's back in the delivery room, and, you know, remembering the sounds or the fear that she may have had after a traumatic birth. And that might come up at a time where, you know, you might just be, you know, hearing someone talk about their birth story and feeling like your body's kind of back in that delivery room. The other part of the brain that gets affected is the prefrontal cortex. That's the pink area. That's the front of your brain. It helps us regulate our emotions, and it helps us make logical decisions. Now, this part of the brain, when we are under stress, often goes offline. And that's why someone might know they're safe or know they love their partner, but their body and their behavior looks like pushing away or shutting down or even panicking. And so there's this disconnect between the knowing and the feeling. The good thing is that, you know, our body is actually doing its job to protect you, right? These functions are essential, because if we didn't have fear, it could be dangerous in its own way. The tricky thing is that the traumatized brain, or someone who had experienced trauma, it's hard to tell the difference between having another birth trauma or sexual assault and your loving partner and safe partner trying to initiate intimacy with you. Like, the brain doesn't know the difference, and that's the part that needs to get that needs to heal, that needs to connect again. So trauma lives in the body. And what I mean by that is when we are afraid or scared, our body tightens up, muscle tension, startled response. And why that happens is because the body remembers that experience. Even when our mind tries to move on, our body kind of can get stuck there. For example, someone might burst into tears during sex and not know why. Like, why am I crying when I should be enjoying this, or I should be connected with my partner? There's this disconnect. Or they might feel numb or nothing at all. And this is an example of how the body really holds on to these protective responses that were created during the trauma to keep you safe. But it's a survival response, and your body remembers it, and it can't. Sometimes there's this disconnect of like not being able to get out of it. And so trauma isn't just psychological, but it really does manifest in the body. So I'm going to talk a little bit about polyvagal theory. And it's really about the body mechanics of trauma. Polyvagal theory was developed by Stephen Porges. And it explains how the autonomic nervous system, which is the nervous system that like regulates our breathing, our digestive system, our heart rate, and particularly the vagus nerve, which is this nerve that goes from the brainstem all the way down your neck into your stomach. And that vagus nerve regulates our responses to safety, danger, and threat. And it's often talked about like it's like your security guard. It determines if we're safe enough to connect, or if we need to fight, or if we need to shut down. So you may have heard the different stages or states of trauma as fight, flight, or freeze. And so this is essentially the same thing, but different wording. So the vagus nerve can determine, okay, are we in the safe and social state? And that looks like engaging, making eye contact, feeling pleasure, connecting. Then there's another state of being mobilized, which is like the fight or flight. We feel anxiety, irritable, or the urge to run away. And then the immobilized state, which is the freeze. We may shut down, go numb, feel heavy, like pause, even dissociate, which means like kind of getting checked out of the current moment and kind of going almost out of body experience. So imagine like a woman who maybe is in her postpartum time, who also experienced a birth trauma and maybe a stay in the NICU. Even though the baby is now healthy, safe, doing great, her body might go into hypermobilize, that fight or flight, when she finds herself focusing on the baby's breathing rhythms, right? Like I think I've heard so many clients talk about there are moments where they're up at night and they're just watching their baby breathe to make sure they keep breathing, right? That person's body is stuck in that hypermobilized, that fight or flight, or making sure and problem solving to make sure their baby's okay, when in reality, like everything is fine, everything is safe. The body is saying, no, this isn't safe. We need to keep making sure that the baby's going to keep taking its next breath. In both those, in that scenario, everything is normal and safe, but the body's acting differently. The vagus nerve is stuck in that mobilized defense mode, and her body's screaming, this isn't safe. And a lot of times my clients have said, like, I know my baby's okay. Like the prefrontal cortex is like, I know baby is okay. Like she's out of the NICU, she's healthy, she's hitting her weight, all the things, but her body just keeps saying, no, baby, this isn't safe. So part of why I'm talking about this is because in order for the body to feel connection and pleasure, the body has to feel safe again. And providing opportunities for the body to relearn this feeling of safety with intimacy is the path to healing. So these are some stats, just some numbers. 1 in 3 women experience sexual violence. Up to 45% of women report traumatic births. 1 in 3 experience pain or fear during postpartum sex. Just think about maybe your friends or yourself or your clients. Trauma is really common, and its impact on intimacy is really rarely discussed. I wanted to share these stats really to validate some of the experiences of many women who are told that maybe they're overreacting or things will just go back to normal over time. But many, many women carry this in their body. And I think and I'm sure, Dr. Lodhi and Dr. Collin, you can attest to that sometimes that holding of trauma in the body can result in some of these dysfunctions in the body. And show up in that way. So let's talk about how trauma, whether sexual or birth related, can profoundly shape someone's experience of intimacy. So many trauma survivors carry a deep sense of shame, fear, or distrust of their bodies or their responses. I've heard many clients share that they felt broken because, a client, she talked about how she froze every time her partner tried to initiate sex. Even though her partner was loving and gentle, her body just couldn't feel safe. Others have said they feared being touched at night because it reminded her of her past sexual assault. Even though she logically, right, knew she was safe, her body wasn't responding. Trust, especially with physical closeness, really takes time to rebuild after that trauma. Even though you trust this person, teaching your body how to trust again. Physical pain. Physical symptoms are incredibly common, as Dr. Lodhi and Dr. Collin have addressed. One client described her body like shutting the door without her permission. It's not just in her mind. This is the nervous system protecting her in the only way and knows how, and it's manifesting physically and interrupting her intimacy with her partner. And then disconnection between emotional love and physical desire. And this one really confuses people. Someone can love their partner and still recoil from the experience of physical touch. I've worked with people who say, I want it. I miss that connection. But when we start, my body goes numb, or I feel like I'm not inside my body anymore. Trauma really splits that emotional closeness from the physical feeling of being ready. So like the brain's saying yes, but the body just hasn't caught up yet. So it's important to normalize these experiences in some ways, that if you've experienced trauma, that this is a normal way for your body to react, though it is inconvenient and frustrating, but it isn't a failure. These are really human, very adaptive responses to pain and overwhelm. And there is a path to reconnecting the dots and getting your body to a place where you feel safe and secure. And intimacy can be built in that safe environment. Let me just look at the time here. Okay, so I have a few minutes. So these are some body-based psychotherapy that I wanted to kind of quickly go over. Some interventions that therapists who are trauma-informed will use include somatic experiencing. This teaches clients to notice and gently shift physical responses. One client realized her shoulders were always tight during touch. Like when touch would come into her, body, or like she would get touched, her shoulders would just go up. And so she learned over time to, notice that and really move into helping her body feel safe and bringing down some of that tension. Sensory motor psychotherapy blends body awareness with emotional processing. A woman might learn to pause and track the sensations before her body starts to check out or to feel numb, right? Like to really learn about what is the process that happens before I get into this, more protective part where I'm checking out of my body. And then mindfulness, which provides you tools in becoming aware of your body sensations, your thoughts, and cultivating this awareness in the present moment. It allows you to create these opportunities to more effectively manage the distress that's going on in your body that's causing the shutdown or the disconnect. The trauma-informed psychotherapy list here, DBT, trauma-informed sex therapy, and EMDR are all extensively studied to be effective in treating trauma. So if you're thinking about seeing a therapist, seeing if, someone who specializes in one or all or any of these areas would be really beneficial. So some intimacy skills to rebuild safety. So we've talked a lot about cultivating safety. That's the path that can foster intimacy after trauma. These are just a few things I talk about with my clients to start cultivating that sense of safety with their partner. So sensate focus. It's a sex therapy technique used to enhance intimacy by focusing on the sensations of touch and kind of removing that performance anxiety piece. An example of this is that I had one couple start with, 5 minutes of hand holding, kind of removing the performance anxiety out, any, expectation of sex at the end, just hand holding to rebuild that physical connection from where they were comfortable starting. Another one is a yes, no, maybe list. It helps clarify boundaries. One of my clients felt really empowered being like, yes, I say yes to cuddling. I say yes to hand holding. I say yes to this, but I'm going to say maybe later to sex and no to this, right? It gave her some agency, and it gave her power back in her own body autonomy, which allowed for her to know what was a green light, what was a yellow, and what was a red. And with her and her partner being able to understand that about each other, by doing that, they were able to change that list over time. But starting where she was, scheduling non-sexual touch, like back rubs, hair brushing, holding hands. These non-sexual touch can reintroduce physical connection without triggering that fear or that expectation, and keeps that body calm and safe while still having some kind of physical touch. And this creates that connection with your partner. The role of the partner. So I hear a lot of my clients say, my partner really wants to help, but I don't even know what to tell him. Or they say, I want to help, but I don't know how, I don't know what to do. So here are some things that you can tell your partner on what to do. If they ask those questions, you can ask them to give you empathy over fixing. Which means listening without rushing to wanting to change the situation or change what's going on. It's not about like, well, maybe you should do this or we should try that. It's about, I hear you. I'm here with you. I know this is really hard and I'm here for you. Right? That feels more supportive than trying to fix something. Another piece is open dialogue about boundaries. Helping both partners feel respected, learning how to check in before initiating any kind of touch can rebuild that trust. So talking about what's going on. And then co-regulation through presence. So using presence, like being in the moment with your partner. If you are in a process of starting to, engage in touch again, and you notice your partner starting to get anxious, or maybe she's starting to look away, or his breath is starting to get faster. The partner can then co-regulate, which means noticing that, and then they regulate their own body so that the partner's body can also follow. And so by doing that, you're leading that regulation and you're soothing each other's nervous system, which is actually a really intimate thing to do. Some other things that I recommend, I talk a lot about creating a felt sense of safety or rituals of safety. So these are seemingly small things, but they actually mean a lot to connection and being together. It really tells the nervous system you're safe right now. So it can be quiet time together. It might just be like 10 minutes of sitting next to each other without pressure to talk or even touch, just being together in this shared space, maybe under one blanket or whatever it is, right? Quiet time together. Sharing meals, eating together regularly without distractions, phones away, candles lit. I mean, it's amazing how much an environment can create like warmth and connection. Intentional transition. So that's like a hug or a kiss when going to work or coming home, saying good morning or good night with intention. That eye contact. These small moments of connection. A lot of people are busy these days, but these moments can mean a lot if we put intention to it, and it's a moment of connection. And so these small moments can build over time to build that intimacy, and then you kind of go with where you both are when it comes to physical touch. Shared sensory experiences using calm music, listening to something together, or a cozy blanket together. Doing something that stimulates your senses in some way, like cooking together. That's like smell, and all these senses are heightened and you're experiencing that together. And then pausing and checking in. So before physical closeness, asking your partner, both of you asking, how's your body feeling? And removing that pressure to have to be a certain way, but just being honest with how your body's feeling and then going from there and building that trust. And then last, movement and breath rituals. So taking 3 breaths together or stretching together or sitting back to back and matching your breathings for some practicing some of that co-regulation that I mentioned earlier. So this is the final slide. It's really an invitation to hope. Healing doesn't mean we're erasing the trauma or making it go away. It really means we're learning to live in your body again. And many clients fear that the connection they once had is gone forever. But we know the body is capable of repair. I've seen it. I'm sure, both of these doctors have seen it too. Trauma may shape us, but healing allows us to choose the shape we become. It reminds us that trauma may have been part of the story, but it's not the final word. Healing isn't this straight path. It often takes a holistic approach to repair, and all of us providers here are trauma informed, and we support folks that are ready to kind of take this more holistic approach in healing their body and their mind, and really having that holistic support can make all the difference. So yeah, and that's my part of the presentation. Happy to take more questions. And let me get out of this sharing screen. I don't really know how to do that. Oh, here we go. But yeah. Oh, where did we go? There was a question. As a fellow intimacy professional, I would love to connect with you all on LinkedIn. Send each of you a request. That's great. Thank you, Danielle.
Thank you.
Great content. Thanks for your support.
Yeah, the 3 of us were talking about making this webinar available, perhaps on all 3 one of our websites. So that might be a way to see this, and the 3 of us, we'll talk offline, but also about making the content available to those individuals that signed up. Because I agree, I think this, Dr. Collins and Shoshanna's, parts were also so valuable and had so much great content in it that I think it would be a shame not to share it. So, I think we're happy to share with everyone.
Mm-hmm. I have another question. For working through birth trauma, are there any resources that you recommend?
Come see us. So I see a lot of postpartum women, and I think, of course, getting evaluated to see where, how has that birth trauma affected your pelvic floor, whether it was, vaginal or cesarean. You can still have trauma with each, and how has it affected you holistically, mentally, medically? Like, all of these factors are so important. I think it's hard to say like what specific resource could potentially help you without knowing what exactly, where are the problems that we need to address. So I would say, getting the evaluation to see where we need to start.
Yeah, I think that's so true, Victoria. And I think so that's the reason why we did this, right? So we just showing you the mind body, kind of almost like the spirit connection. So, Shoshanna talks about the mental health aspect of trauma and how you work through that. Victoria talks about the pelvic floor and the trauma that can happen through there, and the breath work and the exercises and the stretches and all of that are going to help you to work through that type of trauma. And then, I'm a gynecologist that obviously, actually, I still do deliveries. I was doing deliveries last night. I'm actually post-call tonight. I was up most of the night. And so, knowing how the pelvic floor works, knowing the trauma that it can be put through, knowing what a vaginal delivery does to your pelvic floor, knowing what, C-section, can do and things like that. I think it's really important to go see providers that understand that there is a holistic approach and a holistic way that you approach these type of topics and subject matter. And I think that, if it's regardless of if it's sexual trauma or birth trauma or whatever type of trauma, it definitely requires a holistic approach.
Mhm.
And so that's why the three of us came together.
Yeah, I agree that, getting the support you need is first like really wondering like what is the support that feels right for you. I think there's lots of ways that you can go about getting those needs met. But like both of these folks have said, is having a team is really the most effective way. Other resources is like maybe also just knowing that like you're not alone in having birth trauma. Like I think the statistic I showed is like 45% of women have experienced birth trauma. That's incredibly high. So knowing that there are people out there, and whether that is a social support group for you, that's a great resource too, to just know that like, unfortunately it is a common experience. But there are providers here that can be those resources for you.
And I think that if, the individuals that are still left here on the webinar, I think the most important thing to realize is that there's hope, right? I don't want anyone to walk away thinking that, that it's hopeless or that they'll never be able to be intimate again or anything like that. I think that the most important thing to know is that there are hope, there are resources, there are individuals out there, whether or not you want to use your insurance or, if you're able to use your insurance or not, whatever, there are definitely people that can help you. And so it's important for you to know that, that there are, and that you can find them. You can find us.
100%. I think that's, the bottom line that we're trying to say is that although pain with intimacy after a birth trauma or any type of trauma is very common, there is hope to get it treated and to overcome that and to be able to connect with your partner and not feel like you're, to Shoshanna's point, the disconnect of your body, where in your head you think you're safe, but your body is showing a different message. And so I think that, I've seen patients who were not able to connect with their partner since 10, 20 years, and they have been able to reconnect, and it's a beautiful thing. But I will say it does take some work. Things that have happened can sometimes take a toll on you mentally and physically, and so just being open to how progress can be, because sometimes it's not always linear. And I think with trauma especially, you can have days or sessions where you feel like you made so much progress, and then a minor setback can really throw you for a loop, but you're still going along the path. It's just that it can take some time. So ultimately, I just want to provide you hope and support. Like, we are here for you, and we are here to help you if you choose.
Yeah.
And I think what'll be helpful is that, once the recording is up, we can send all three of our information and our websites for you to check out our websites and learn more about us. And if you decide that making an appointment with us is the right thing for you to do, then I would invite you to go ahead and take that first step in the healing process.
Yeah. I think a lot of resources out there is like kind of a big blanket of like trauma resources. Like I can think of like so many books that talk about trauma and things like that, but like not specifically birth trauma. I feel like, I think two of you could probably speak to this too, is that like women's health isn't really talked about very much. And I think there is a lack of resources too, in some ways, of what is available to people. So I think this is also why we decided to do this talk, is to let people know there are resources out here, and providers that unfortunately it's not talked about enough.
100%.
Yeah.
Absolutely. We're grateful for all of you spending your hour with us and coming to learn this information. And definitely, if you found it to be of value, please share with your friends and let them know that we are resources for anyone in the community to find help in healing, and that we're here to serve and to help you move forward in your relationship and in your journey of healing.
Absolutely. And if you work with us providers, like all of us, we talk, as long as we have your consent, we talk with other providers to make sure that you have like a team working with you, right? Like that you're not having these like separate providers that are doing their own things, but we're gonna, if you give us the permission, we're gonna be the team for you and be in communication with each other too.
Right. And it is a collaborative effort, right?
Yeah.
So in an ideal world, everyone would have access to a pelvic floor therapist, a therapist, and a sexual health doc.
Yeah.
to help them get through. Right. But we're here to serve. So
yeah,
we're happy to help you.
Definitely expect an email from us to follow up for information, and reach out, whether LinkedIn or email or phone call. Whenever we'll be available.
All right.
Thank you guys so much. And we look forward to connecting and helping with you guys more after this.
All right. Thank you. Have a great night.
You have a good night.
Bye.